So attendees are coming in now, so you can go ahead and get started whenever you're ready.
Okay, wonderful. Hi, I'm Dr. Elisa Shippon-Blum. I am the president and director of the Selective Mutism, Anxiety, and Related Disorders Treatment Center, or the SMART Center. I'm the president of the Selective Mutism Research Institute and founder and director of the SMA. I'm here with Jenna Blum.
Hi, everyone. I'm Jenna Blum. I am a fourth-year doctoral student at Chestnut Hill College. I'm also the director of Communicamp Counselors and a lead clinician at the SMART Center. I also am the vice president of the Selective Mutism Research Institute.
We are excited today to present to you SM Through the Ages, which is coming to you from about 25 years of experience and thousands of individuals with SM.
So why did we decide to present on this topic? So SMART Center has been around for over 20 years, and we've seen thousands of different individuals. We find that the individuals of different ages present in different ways. So SCAT concepts are the same for all ages. However, the treatment focus changes based on chronological age, developmental, and cognitive functioning.
We wanted to discuss a bit about how we conceptualize SM. We see SM, as many do, as a social communication anxiety disorder, where mutism is merely a symptom and it's more than just not speaking. We believe there's contributing factors, and the research shows that there's factors into the development and maintenance of SM, being timid, sensory processing disorder, some learning challenges with processing being the most common, speech and language disorders where 30 to 40% of the kids have them, being bilingual, parenting styles, environment, etc., all contribute to a child's social communication anxiety. Also, communication changes from setting to setting and person to person. So a child may be mute in school with somebody, but come home on a get-together and be completely verbal. The social communication bridge is used to assess an individual's stage of social communication at home, school, real world, and all other avenues that the child or the adult participates in. Just a real quick overview of the social communication bridge, the 4 stages: non-communicative, shut down, or when somebody is speaking in front of others, but ignoring that person. We all know the nonverbal stage, stage 1, pointing, nodding, writing. And are they responding? Are they initiating in these environments? The communication stage of stage 2, which we call the missing link. That is where we think with comfort, a lot of individuals believe that a child will, or an adult will, just progress into verbal communication. And we find that's not always the case. So we need to be pretty strategic. So we want to know, what is their baseline? Are they able to tell someone something? Are they able to use sounds to words? And we will strategically help those individuals who are stuck to be able to make that progress doing that. And of course, there's verbal communication, or stage 3. And that's when somebody's either quiet, 1 or 2 words, or elaborative, loud, initiative. So it does range the verbal stage. So our goal is to determine an individual's baseline stages and then use strategies and interventions to help them make the progress.
So an overview of the social communication anxiety treatment. So SCAT is based on treating the whole person and not just mutism. We find that SCAT is not a separate type of treatment, but rather it incorporates several approaches. You will see how these therapeutic approaches change with age, and we'll get into that later on in this presentation. But just some of the therapeutic approaches that we talk about is behavioral. So these are exposure-based treatments. These are like child and parent games and goals that we implement. There is cognitive behavioral therapy. So really getting into the thoughts, feelings, behaviors, going through the CBT triangle with children that are older, really talking about cognitive distortion. So really trying to reframe these negative thoughts. There's a family system approach as well. So really looking at parental dynamics and how the system functions entirely. So really providing psychoeducation on the importance of working together as a family unit and what that might look like in treatment. Lastly, we also have an insight-oriented approach and motivational interviewing. So this really helps clients to understand their own inner workings and motivations. And so for those individuals that aren't as motivated in treatment, we really try to explore how we can help them make those changes and really meet them where they are. We also included our research link here, and we have many different research studies on selective mutism and the effectiveness of SCAT. I actually did present a poster for the SMA conference this year, and we have plenty of different ways to kind of talk about how different ages contribute. We also wanted to include this picture on the right, which is one of our, which is an example of an individual who's very understanding of their treatment. You could see that he's drawing himself across the bridge. And so we really try to involve these techniques throughout our treatment.
So how does treatment change with age? Let's start with the preschool child. I will say, and I want to reiterate again about how some of the concepts I'm going to talk about and Jenna is going to talk about don't just stop at a certain age. I think we know that. So you're going to see things coming, going, and so forth. And I want to just kind of begin with preschool, but you'll still see it pour over into elementary and junior high and high. From an emotional, behavioral, and cognitive presentation, SM is seen upon entrance into organized social settings. Typically, parents will say, yeah, I thought my child was just shy. Typical presentation is a very shy, sensory sensitive child. However, we've learned through our research and just working with these individuals that there's a percentage of people, kids, and again goes into adulthood, that have what we call the whys of SM, factors that contribute to why an individual developed SM and why it's continuing. Learning or processing challenges are the most common learning difficulty, sensory processing disorder, speech and language, pervasive delays, such as autism spectrum disorder. Many preschoolers have emotional regulation and behavioral challenges, frustrated easy, tantrums, parents are at their wits' end, they're not sure what to do. So we do see that often, and it's sometimes, it's often associated with sensory processing as well. There's something called the quad that I developed when that term, because I saw very early on eating issues, picky eating, sleeping, behavioral challenges, toileting issues. And that I call the quad because you sometimes see 1 or 4 of those, and that has to be involved in the treatment process or the whole child approach. Typically, preschoolers feel scared. It's like the deer in the headlights. And often parents do speak for their child and the child shadows. It's often a time where parents are encouraging their child to engage and verbalize even when the child may not be able to do so. The focus on specific interventions, external motivation is really important here. Through natural kind of setting up the world, which we'll see with parents and teachers, children play games. It's not goals, it's not to speak, it's games based on where they are on the bridge. If they're capable of speech, of course, the games are to help them become verbal right away. But a lot of times it's engaging activities and other games that allow for give, take, back, forth communication. And with that, children tend to progress into speech as they're playing their games. The children also, preschool, can get verbal very quickly through fun or interesting tasks or interests. We see that at camp, at Communicamp. We'll see the young kids progress into speech very quickly, whereas as the older kids are involved in camp, more strategies are needed to help them make the progress. Again, helping them relate to a feeling is important. They tend to feel very scared. You see that deer in the headlight look. Something called silent goals. What is that? That's when the world is set up for them. Play dates, small groups, how to ask questions, when to ask questions, and so forth. Parents and teachers need to do that for these little guys because they're not just going to necessarily begin to engage and speak. At this point in a child's development, they're not really identifying themselves as being mute. They don't, I mean, I'm not saying that some can't, but the typical preschooler doesn't see themselves as the kid that just doesn't speak. Kids mirror their parents, so we have to be very careful with this in terms of the anxiety, the worry, the fear the parents are projecting onto their children. So often I'll see in session where a parent is very nervous and you see the child looking towards their parent, and that kind of causes them to feel, hey, there's something to be scared of. So training parents on this is going to be a very important piece here of how to kind of change their affect and their approach. Don't wait, facilitate. We saw this in our research. Implementation is key. We can't just wait for comfort We create it by what we do, social comfort. However, facilitating strategies, knowing how to ask questions, bringing children into communication through how we ask questions and when we ask questions is important. I can't emphasize enough the importance of structure, consistency, routine, and predictability in a child's life that gives them a sense of control. Here's some typical games and activities that we play. Again, we're respecting this stage on the bridge. We're also respecting their whys of SM. So the games they're playing, simple things like scavenger hunts, looking for things in a store, games to play with friends and so forth. It's fun games, and they may be getting stickers or rewards to do this. So these external motivation, using stickers, points to get and play these games as a result, cross the bridge. Again, meeting them where they are on the bridge. The transitional strategy is very important. That's bringing them in through choices, through visuals. So rather than tell someone this, it's, hey, do we want this or that? No answer, this or that, tell me. So we start involving the child into the social communication process right away, using the choice and visuals, but also engaging. A lot of these kids are shadowing, as I said, so they're not necessarily engaging. Educating others, we have a sheet called About My Child. It basically kind of helps others understand how to engage with the child. And we have to be very careful with loud, large, lots of people environments. You will see a child bridge down in loud, large, lots of people environments, and they're able to bridge up in less crowded, quieter, smaller locations. So that's where we want to practice our goals. Again, I indicated that most of these kids are very sensitive kids. In school, we see in preschool IEPs when there is a need for it. For example, sensory processing, some learning or developmental challenges. Very often we don't have formal accommodations, but we will need it if this child is not able to make the progress. So meeting teacher with parents and peers, knowing the concept that comfort precedes communication and progress doesn't happen in a group. I really want you to think about that. You'll see that through the buddy process, small groups in the room, the same buddies coming over for get-togethers, doing lunch bunch and so forth. That's where you're going to see the progress. It's not going to be in the middle of a group. Visuals again, and choices. One reason we use visuals, and you'll hear this throughout, is because we want to minimize an individual's need to think and process. So when you see something and you hear a choice, you're not having to think about it a lot. And we know that with anxiety, we get nervous really quickly. So having that visual and hearing those choices is a great way. Of course, we're going to bridge up to direct questions without visuals, open-ended, thought-provoking questions. But a way to get these kids started is using those visuals and choices that you will see throughout this process. Minimizing direct eye contact, that helps many of these kids. Respecting warm-up time, re-asking a question, giving them some leadership roles. If they're great at a puzzle, heck, let them be the one to help their peers or a buddy or another child, because that gives them confidence. Reproducible task, what is that? That's the same activities over and over. Why? Because they own it, they know it, the same books, the same puzzles, the same games. And that again helps them because they know it, they don't feel as anxious. We do need to depend highly on adults to implement. We can't wait. So training teachers, training parents on how to implement is very important. A really key strategy that we use with the younger guys are phonics, cat, dog sounds, really helping them use that as a starting point to be able to progress into speech. That's just done informally in the classroom, at home, playing games like chalk time with phonetics. It's a great way to help them make that progress.
So now we're going to talk about elementary school. This is typically like 6 to 9-year-olds. One thing I want to emphasize is that preschool to elementary is not a major change, but a child is becoming more behavioral to cognitive. So they're becoming more aware. So therefore, the treatment will change to adapt to this awareness. From an emotional, behavioral, and cognitive presentation, these individuals, typically these are 3 to 5-year-olds whose SM has solidified because the symptoms were not properly addressed at a younger age. So whether this child never sought treatment or they didn't find treatment success, not finding treatment success might have looked like misinterpreting those whys of SM or having too much focus on speaking when the child wasn't even engaging. So really this mutism is becoming more conditioned, which means that these children are more avoidant. There's more awareness of mutism. So these individuals go home and they're more aware, and they might tell mom, like, I know I don't talk in school, right? Or they might just internally have that dialogue with themselves. They either avoid speaking, or this is also a time where they express an interest in speaking. So this could be a time that a child determines, hey, maybe I want to actually go and try to seek help. If present, this is also where delays become more obvious. And also, these individuals identify with feeling scared, but actually, as they start getting older, they also start to identify with it being hard to do. So because it's more conditioned, they're at this point where they're realizing that this is more ingrained in me. This is harder for me to get through this. They're kind of stuck on that nonverbal wall. That being said, speech phobia may emerge, which is where you're stuck against that nonverbal wall. And typically, these individuals look and appear as professional mimes. So, external motivation is still very crucial, but this is also where internal motivation starts to emerge. This is where individuals start to realize, okay, I need to do this for myself. Behavioral strategies are key, but because these individuals are becoming more cognitively aware, CBT interventions are needed. This is where we start talking about the CBT triangle, talking about their thoughts, their feelings, their behaviors, how they all coexist. How can we reframe some of these negative thoughts? Not talking or shy becomes a part of their identity. So, this is how they kind of look both to themselves and from others at school. And you can see how that persists throughout the day. Interventions needed to unlearn these mute behaviors. So because mutism is more conditioned, there needs to be more strategies to really unlearn these mute behaviors. Games become more active, so they actually become more goal-like, and that means that these individuals are starting to complete their own goal charts. So rather than just facilitating going out, practicing the scavenger hunt, doing all these things in preschool, these individuals, and you can see on the left here, they're starting to really start to draw their own goal charts by themselves and take that ownership and independence. Parents, school are still setting up the world for them. So these are still young kids. These are like 6 to 9 year olds, but they're still gaining that independence through kind of doing more of that goal work. This is also a really crucial age for starting to really understand the bridge. On the bottom right there, this is an example of one of our camps, Communicamp. And this is where we actually spend time really walking through this bridge, really breaking it down for each child in a group setting. And we actually show each other our bridges and show each other where we are in school versus where we are at home, where we are maybe now at camp versus where we were the first day of camp. And so it's a really big moment for them to really realize. More specific focus and specific interventions. So really starting to pay attention to the misunderstandings, the mismanagement, the misdiagnosis. Like I said, maybe these children didn't get to the whys of SM prior to the treatment here. And so we're really trying to get to some of these misunderstandings that are going on for them. We want to acknowledge and assess. We want to demystify. That means that we really want to talk about their feelings charts. How did you feel when you were there from a ratio of 0 to 5? Then versus now. So on that top left picture, you see someone who drew where they were then versus how they feel now. You also start to locate yourself on the bridge. So on that bottom left picture, this individual is showing where she was then is highlighted in yellow. You can't really see it that well, but it's on the left versus now she sees herself as crossing the bridge. Drawing these bridges and doing all these feelings charts also provides a sense of control. And so similar to these preschool kids, we want to add structure, consistency, routine, and predictability, because not only does it allow that control, but it also gives them this sense of ownership. Charting an awareness to their feelings and location of the bridge also gives them that sense. And then lastly, really adding this give and take of communication. It's key. So adding interview games, poll games, different types of games to really practice initiating versus responding and really getting them in more comfortable with those people around them. So going into the home in the real world, so similar to preschool kids, a lot of these are similar. They're still engaging strategies such as handover, takeover, frontline, exposure, right? We want to try to practice doing 100 different exposure in 10 days. This could just be handing something over every time you go to a store or restaurant. We want to keep exposing them. Also, transitional strategies start to adjust a little bit in the sense that while preschool kids, verbal intermediaries are more parents, teachers, people that really facilitate for them, these individuals at this age really start to notice that their verbal intermediaries become more purposeful. Maybe a verbal intermediary is a best friend at school or someone in a club with them. And so we're really starting to notice that they're starting to own this and they're starting to pick and choose. Also, these individuals not only enjoy doing fun sounds and phonetics like we talked about with preschool, but they actually start to do a process called our ritual sound approach, which we're going to get into in a second. And that's actually a very structured way of getting into sounds. Similar to preschool, we want to add buddies. So play dates are really critical. This age range, socialization is key for 6 to 9 year olds. So we really want to start implementing buddies in and outside of the classroom. Hobbies are needed. So really, also noticing to have the hobbies outside of the large group. So keeping them in small groups, but really trying to pick what they like and then own that. So for example, if we want to have a small group, maybe playing soccer with 1 or 2 buddies in our backyard versus a large soccer team, thinking about what will work for my child, what's attainable. Lastly, we want to really continue the awareness of loud, large, lots of people. So we understand that we can't avoid them necessarily, but we want to know that in these settings, these individuals might have to bridge down, and that's okay. Lastly, with school. So thinking about the difference between a 504 versus an IEP. For IEP, this taps into more of the comorbidities and social communication function. The same concepts as preschool apply in school, but the child has more awareness. So we want to be very aware of the expectation that we're placing. What does a teacher expect of me? What am I going into today? We want to keep doing play dates with buddies. Again, we want to prioritize those small groups, both in a particular spot in the classroom, but also out of the classroom, which could be lunch bunch, friendship groups at recess. We want to work with different staff members like SLP and counselors to really start to really make sure that we know what's going on in this school setting and know how to help this child. Lastly, school education is key. So it's not just about being in small groups, but it's what you're doing in those small groups. So thinking about how are you asking these questions to your child? When do you ask these questions? With who do you ask these questions to? So if you look at the picture on the right, on the top, you have a teacher who's very engaging with this small group, but you notice that she's focusing on the task, she's avoiding eye contact. She might focus on 1 or 2 of the children that don't have SM first to really start acclimating this child into that group. Versus on the bottom, you have a teacher who's staring right at the child, who's not looking at the task, right? So you can see that there's a higher expectation in this situation. So at the end, we'll see if we have time to show this video, but we really wanted to talk a little bit about sound work or RSA. So RSA is the ritual sound approach. This is in our transitional stage, stage 2. It's important to note that not all children benefit from RSA, but those that do really enjoy it. So
Jen, I think we can play it.
we do have time?
Yeah, I think we're great.
Okay. So when it comes to RSA, before we play the video, it's important to note that it's not about lowering anxiety as much as really a way to unlearn mute behavior. So these are children that are stuck on the nonverbal wall and need a structured tool and a step-by-step process of progressing themselves across. You can add people to your club one by one, and you see that on that this side on the right, this child wrote one by one who's getting added, and you see that there's a step-by-step process by adding 1 more sound, 2 sounds, then you start doing 3-letter words and so on. Charting to give a child this sense of control is really key. So having them check it off rather than you. And yeah, so maybe we can show this video at this point, and then at the end, if you have any questions, we can answer those.
Yeah, and one thing I would like to say also is that a lot of these kids with the anxiety aren't feeling that way. Like they're not anxious, they're stuck. So you can lower anxiety. I make a joke of sitting on a hammock with a pina colada. I mean, they're comfortable. So the strategy of progressing them as they make this progress and use charts, this isn't what they're going to be using forever. It's a starting place. We end up minimizing the number of columns. They're very aware, and that's important because that helps them overcome this challenge. All right, so let's try. Let's do a blowing sound. We can try our feather. Go ahead. Super blower, go ahead. That's great. Your turn. Good. How about the blowing with our teeth on our lip? Perfect, and that's the F. You want to cross off the letters that you're doing now? So you've crossed off the W. Go ahead. F. How about pushing air through your teeth? Perfect, cross it off. And what we did was, we also got to other sounds. Deep breath in and a deep breath out. Good, perfect. Perfect. These are coming too easy. Now, how does it feel on your chart to be able to do that when you're putting sounds together or just putting sounds? Your teeth, great. So it's easy. And sometimes if you thought about it when we first started, you probably would have thought it was up in here, right? But just thinking about the sounds makes it so much easier. Where do we go from here? How about, well, there's our bridge. Let's see. These are 3-letter words. And here's our S sound. And I asked you, do you like dogs? Great. Do you like playing with your friends? Do you like candy? Easy as pie. And then you went right to your 3-letter words. Remember I taught you how to underline? Your turn. And you're being a show off, but you're not even underlining. It. At. Keep on going. Perfect. Keep going. Good. Yep. 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 And then who's your friend that comes over? Yep. And then you wanted to read me questions because you're able to do that. Go ahead. Love them. I love them. Go ahead. Now you read the next one. Love it. Yep, especially chocolate. What's your favorite candy? Chocolate. You like chocolate too? What's your favorite ice cream flavor? Chocolate. You like everything chocolate, don't you? Do you have a favorite kind of chocolate candy or all chocolate candies? All chocolate candy. Me too. We're the same. It's great. You did an awesome job. And what we started out doing, which I think certainly helped you, is we drew the bridge. I'm going to show a picture of the bridge. And we showed you right there at the bridge. And here at the bridge is when the words didn't come out, right? Here is when words come out. And I was telling you how some kids start to think about sounds as a first step to go across the bridge, especially if they feel like the words are stuck, right? Like in school and stuff. So if we think about the sounds, just like you did, we can kind of walk across the bridge to where we do the sounds. We push air through our teeth to make an S, and even do the yes word, which we don't even have on the bridge, but if we were to write yes, yes. So when I said, do you like dogs? And you went, I could have said, as you moved across the bridge, do you like dogs? And what would you have read? Yes. Right. And then we went right to 3-letter words. Cat, sat, hat, pat. Now, if I said to you, hi, when I saw you, what could you say to me? Hi. Great. So you went right across the bridge today, didn't you? Awesome. You did so well today. I am so proud of you. Are you proud of you? Like how proud? Like super proud, really super duper over the top proud? How proud?
Super proud.
I'm proud too. So I love that video. This girl had been mute with all her peers and relatives and so forth. And this was what we did in session. And because she did it once, I wanted to reproduce it actually for her teacher. So that's why we redid it again. But you could see how she imitation was important in that. Her awareness. Often we'll have patients come to the Smart Center and they've been in therapy to lower anxiety, but what's often missing and needs to be in all treatment plans is, in our opinion, really helping these children understand, because that gives them the control and learned long-term coping skills. RSA stands for Ritual Sound Approach. It's a very controlled step-by-step process to help kind of kids stuck in the nonverbal unlearn their mute behavior. And it's typically done with people that they know, whereas in stores and restaurants and strangers, we obviously don't do this. Let's talk about junior high now. From an emotional, behavioral, and cognitive presentation, we find this is a fork in the road. There's primarily three types of high school students that we see. The socially isolated individuals who can speak to some, may not be elaborate in initiative, but they can speak, and they may have a couple really good friends and speak to various individuals, but they're mute with others. We see the highly reinforced or the speech phobic, kind of an exaggeration of what I was just showing you with that little girl. They may be mute with everyone. Maybe they're even mute now with their parents, so it progressed. But they're mute with, let's say, all relatives, maybe with all peers, but they'll speak to teachers, or they're mute with all adults, but they'll speak to peers. There's really a wide variety of ways that some of these speech phobics present. Then there's the kind of junior high student that has these delays, and we have to understand them and really incorporate these delays or challenges into their treatment plan and help them reach their capacity. Typically in junior high, we see a more global dysfunction. This is where we're seeing more social isolation, more emotional distress starting, more academic implications, and a little more global dysfunction. Some of their friends that they had in elementary school, unfortunately, are moving on. Not all, but some. Depression starts to emerge here. We don't tend to see it as much in the younger folks, which is interesting. We tend to see it in this age range start to show. And also the worsened anxiety may emerge as well. They start to identify really in terms of their beliefs are kind of maladaptive. They start really getting negative on themselves. People don't like me. I'm stupid. That person's mean to me. And this really is something we need to work on in therapy, because this can really cause more avoidance. They either want help or they don't want help. They're either very avoidant to the topic, which is really hard on parents, and they don't know what to do and they're at their wits' end, or they're really willing to talk about this and work on this. And this is where parenting styles are really important. And we see how parenting styles really do affect treatment. And that's something we work really closely, intensive parent management with the kids, with the parents, to help these kids. They're more conditioned in junior high. They might look less anxious. Are they defiant? Are they being difficult? No, they probably have learned to be non-verbally comfortable or minimally communicative, and they're comfortable. So they don't necessarily look anxious or scared, which is why some individuals can see these kids as being defiant or difficult. They tend to relate to it's hard to communicate. Well, that makes sense, right? The behaviors become more conditioned. They know how to get their needs met without having to verbalize. Again, speech phobia is more entrenched. And again, if it exists, we really need to tackle those developmental delays and comorbidities incorporated into treatment. I consult a lot with schools, as does my team, and we'll find that if there's a child with speech and language issues or processing issues or learning challenges, they tend to see this as separate. And this is an area that we need to realize is probably factors into either the development and or the maintenance of SM. So they're often not separate. Individuals with processing issues and speech and language are very common in what we see in terms of these comorbidities and what's affecting these kids from making progress. Learned helplessness. The child may feel incapable. Their self-esteem is really starting to drop. If it hasn't already, they become very dependent on their parent. Their parent tended to continue to speak for them or do for them. And they're very dependent, and that doesn't make them feel good. The child also continues to sense Again, remember we talked about them being very sensitive and aware children. They sense their parents' apprehension and anxiety, and this can cause more avoidance. The child's SM is part of the parent's identity. The parents truly struggle to shed that identity. I'm a mother of a child with selective mutism. They almost don't know how to not be that mother because they often have gone years trying to help their child, or they feel very lost. And we have to help parents deal with these fears and work with them on that as well. We have to help these children have a roadmap for new habits. What can the child do on their own, and help these parents navigate that with them? And again, some of these parents are struggling to let these kids go because they have that like kind of learned helplessness or almost a codependency. So we have to work closely with these parents that are manifesting this. Specific interventions. You can see on the left, this is a junior high student in terms of their writing their goals. It's very CBT based. As Jenna and I were talking about, that SCAT is not a specific isolated type of treatment. It incorporates various therapeutic modalities and different types of therapeutic therapies here, in terms of CBT being very, very critical for junior high students. Getting more and more as they get older. We started in elementary, and it's getting more and more a very cognitive process. Acknowledgement, assessment is very important. When I did this goal, that again is set up by the clinician guiding them. What did it feel like when I did this goal? What would it feel like if I had to do it again? So you can see the child was writing that in their journal. Less silent goals. This is a more proactive. Internal motivation is critical here. We really need to help them become motivated and see this as a way to make them feel more confident, more social, more engaging. And although some kids can come in very avoidant, we do find that as we work with them in therapy, their internal motivation definitely increases. And of course, external motivation can still play a role. As you see with the boy in the poster above is going on a camping trip with their parent, and they're working towards doing that. The child is very involved in their goal setting. Of course, we have to change the terminology. Instead of games, and we will talk about assignments and goals, and it's very age appropriate and based on where they are from a cognitive and developmental standpoint. Developing independence is very important. Again, the fork in the road. This is where we see the dependence. This is where we really need to really make sure these kids are developing independence at home in terms of their own chores, things they're doing on their own, getting together with others, going to other people's houses, hobbies, interests. That's where they're going to find their peeps. That's where they're going to find their friends as they get older, in their areas of interest. Again, in the real world, we're doing the same concepts that we talked about, right? They're very active in their goals. They're not having pictures. They're writing it down. Below is an action plan that we will begin. Again, respecting their stages on the bridge. If the child is verbal, then they're working on verbal. They might be scripting it. They might be working on open-ended. It really does depend on where they are on the bridge and how they're progressing through treatment. But an action plan is, where are they going? Who's going to be there? What will someone ask? What is the answer? What could you ask? So really helping them plan these social situations and what types of communication could occur. That's going to help minimize their need to think and process, and it's going to lower their anxiety. The verbal intermediary is very important as well. We teach parents, again, to be able to bring them into communication, verbal communication, through choices and helping them, instead of the child naturally beginning to or continuing to shadow. So we still emphasize the verbal intermediary if the child is standing in the background. We also have to give them goals of going out and about. We start to see these kids becoming a little more reclusive at this age. Give and take. You think that once they're comfortable that these kids are able to have the give and take of communication. We don't see that. We see a lot of kids struggling with conversation starters, knowing how to elaborate, how to initiate with friends or people in school. They really have a difficult time. So really working through strategies and interventions on helping them with the give and take of communication through assignments and practicing responding and initiating is also very important. School trainings, once again, very critical. IEPs, 504s are needed. And again, that's based on their level of functioning or dysfunction and whether we choose a 504 or an IEP if they're in the public school setting. Rotating classes are difficult now, right? It's difficult. We have to be really creative. We still need buddies. You can see in the picture, sitting with, paired with, grouped with, the conscious effort of teachers doing that. You see the papers they're working on. Maybe the child with SM is reading the directions if he's verbal instead of having a full-blown conversation. We see teachers purposely asking questions, approaching the child on the bottom rather than in the middle of the class. So again, it's meeting the teachers, talking to the teachers and meeting where the child is really, really important. Using the verbal intermediary can be powerful here too. Using a peer or a teacher that they're verbal with and knowing how to do that within the school or social settings is important. Again, don't wait, facilitate. Even for older kids, waiting for them to make the progress is really going to be waiting a long time. We really do need to facilitate strategies and provide the opportunities. A really great strategy for kids as they're progressing into speech to minimize their need to think and process is the write and read approach.
So now we're getting into high school. These are teens, and teens are tricky. So from an emotional, behavioral, cognitive presentation, teens either really want help or they don't want help. For those who really want help, these teens typically are the ones that are kind of bringing their parents into session, like, I want to be here. They're the ones that are really motivated. But on the opposite end, if you don't want help, these teens are seen as highly reclusive or socially isolated. They don't want to be there. Maybe their parents force them into treatment. What tends to happen is either there could be a dropout rate quickly, or we could start really trying to think about how can we build motivation. This is where motivational interviewing is really important. So we really try to meet someone where they are, and instead of telling them why they need to get here, we tell them it's okay. We normalize that for them. We understand it's hard for you. How can we meet you where you are? Maybe that's bringing your goal sheets back every week. And even if they're empty, that's okay, but at least you're trying, you're coming. These teens may be more avoidant, or they might have a core group of friends from childhood. So they either are more avoidant, don't really want to engage, or they have that level of comfort. They have those one or two core people that have been there with them. Those typically, when they were younger in preschool or in early elementary, were probably those kids that were like those speakers for them, right? They were probably the ones that were talking for them in class, and they've kind of grown that comfort throughout time. At this point, SM is deeply ingrained in their identity. So from years of avoidance, it really creates exponential situations. So that basically means that, these teens might have superficial relationships. There's lack of natural opportunities to build skills, so they might not feel as comfortable. They might have situations where they engage, but they don't know, how do I ask someone what they're doing over the weekend? How do I go beyond just the typical how are you question? And this is where we start to implement different strategies like I am statements to really add on to just a simple answer. So ownership and motivation are critical. Goals are active at this point, so we really want to start educating teens, providing that psychoeducation on not only completing these goals, but why are you completing these goals? We want to also educate parents to step back. So at this point, this is where not only is goal work about trying to increase our level of comfort and communication, but it's also about trying to increase our level of independence. These teens, most of the time, have been stuck to our parents, right? And so we really want to kind of break away from that. We want to start self-reflecting. Many of these teens have journals and write in them and come weekly and kind of show their journal prompts and really start reflecting on how they're feeling internally. We want to add there's a strong cognitive component as well. So we want to really emphasize, how are you feeling? How can we reframe this? How can we flip this negative connotation? There's direct goal setting and education. So again, really kind of giving them that psychoeducation on, why are you doing this goal? What's attainable for us? So instead of just saying, all right, yeah, I'm going to go to a store and do this or that, let's be specific. Let's actually break down, what days are you going to go? When are you going to go? Who are you going to go with? What are you going to ask? So really being directive. In this stage, highly motivated parents are obviously a big part of this, but there's also parents who have difficulty letting go. These are parents that don't want their child to grow up, but they want them to just start engaging. And so if you're not letting your child let go, you're never giving them that opportunity. So we really want to create new family patterns using goals. We want to address, reinforce, learn helplessness. This learned helplessness doesn't just have to be our teens. This could actually be different family members or parents, grandparents, aunts, uncles, older individuals. And so if our teens are watching, you know, us being learned and helplessness, they're going to kind of mirror that. And so we want to really be mindful of our affect, similar to what we were saying about preschoolers as well. Teens need to develop areas of interest and opportunities for socializing. So typically there's low self-esteem and there's a lack of confidence. So can we find something that we're good at? Can we find an area that we want to focus on? CBT strategies to reframe these negative self-thoughts. Teach cognitive triangle, right? Going through the thoughts, feelings, behaviors. And at this point, SM is a big part of their identity. So we want to try to break away from that and think about where are other places that I find myself? What is my identity outside of just SM? Lastly, with specific interventions. So with school, similar, you want to have that IEP 504, but it needs to be more creative. So you want to account for switching classes. You want to use clubs, activities, different areas in school that could be utilized. You want to have one-on-one small group meetings with teachers. So really trying to incorporate all of your teachers, not just one, but at this point, they're going from different class to different class. So you want to talk to each teacher individually, see what's going on, how can teachers kind of convene together. Same class seating if possible. So even though they're switching class to class, is there a way that we can build some sort of consistency, right? Can we at least sit in the same seat every time we walk into English class? Can we sit in the same seat next to our peer in math class? So we want to keep that consistency. We want to focus on consistent responding. So we want to do this by having teachers implement choice questions, direct and prompt. We want to have us write and read. So rather than, waiting and being okay with kind of that head nod, can we have them write and read? Can we have them write down their answer and then read it off a script? That being said, we want to focus on initiation, and that is through script approach. So this is where, some kids or teens might not be as comfortable asking, right? We might just be like, oh, I won't bother with it. So can we use, a pen and paper? Can we try to really script out, how are we going to ask them this question? It's easy for us to kind of have this give or take of communication, but if we didn't have this PowerPoint in front of us today, we probably would be off guided. So a script really allows for that. We want to also provide a big shot role, so really helping our peers. We want to maybe implement ways to kind of help even the younger kids. So maybe we want to be a math tutor. Maybe we want to help younger students in various ways. So really adding on to that big shot role. And lastly, really including these clubs and activities. This is where teens really blossom. This is where they find their people. This is where they go to science club and they're like, wow, finally, I found people that are similar to me. So we want to really add those clubs and activities into our goal work.
As we begin to talk about adults, again, it's a continuum, as you can see. In talking about kids in elementary and junior and high school, I want to add also that some of these kids have confidence in a lot of areas of their life, and it might just be this area. So as we're talking about, we understand it's not necessarily global low self-esteem, but we do see kids over time, which again goes into adulthood, which is what I'm going to talk about, where their overall global dysfunctions of lack of peer interaction and kids moving on, and really the school having difficulty knowing how to accommodate and do interventions, it really does become a time when you do see these kids become avoidant, and depression and worsening anxiety exist. So with that said, in terms of emotional, behavioral, and cognitive presentation for adults, we see two types. They tend to really want help, and that's all about the adult. They contact our center, they want help, nobody else is involved. Sometimes the parents may be involved and often need support to step back. And that's something, again, as we're talking about that kind of parents not knowing when to let go, and us almost holding their hand as we're helping them let go, because they want their children, they want their kids to get over this and to have help. But by the time they're adults, it really becomes the adult and the older high school student, for example, their self-esteem is going to be affected negatively just by how others are treating them. So we need to really be aware of that and add that into our psychoeducation and support for the caregivers and people in their lives. So, or not just the person wanting help, but the parents or grandparents are the ones contacting us, like a high codependence or just my child or my young adult or my adult child. I mean, we've had adults as old as 50 years old with their 70-year-old parent contacting us. I mean, we've had a ton of different ages where you still see this dependence and the parents not knowing how to let go. So we need to work with the adult to build that internal motivation for the ones that don't want the help. And again, that's going to be really tough because now they're adults. And as we talk about, that need for internal motivation is really what it's about. Adults with developmental delays need more support from parents and outside therapists. So we do need the parents and caregivers to be involved with some of these adults if there's additional challenges that they have. We do see more depression, more socially isolated. Some are having troubles with jobs, reaching their academic potential and so forth, partly because of all the opportunities they might have missed. Their lack of confidence in social communication. Again, they may be able to speak, right? They might be able to say hi. They might be able to ask for something, but kind of the give, take, the elaboration, the initiation, the kind of the conversation starters, knowing how to have friends, keep friends. That's really what's on their mind and what they're really struggling with. They often have a very strong awareness what the SM is playing in their life. And we talked about the fact that that they usually can speak. And that's really important to know that we rarely see an adult completely mute. They usually can speak with minimal effort. It's all of the things we were talking about being initiative and elaborative and so forth. Specific interventions, one of the most important things we do, we talk about their personal and professional goals. Even with teens, I'm going to back up and say, knowing what their individual goals are important as well. It just becomes even more so here because they're adults. They need to want this. They need to own this. So helping them outline their goals and respecting what their goals are. They may be very different than, let's say, the caregivers or the people that are having relationships with in their life. So their goals may be completely different, and we need to respect that. Adult writing out plans, as you can see what their goals are, and you can see the acknowledgement here. They're acknowledging their challenges, they're assessing them, they're rating their difficulties and doing things. And we are respecting that as we move along in treatment. We have to understand that what might feel hard for them is hard. And even though somebody else in their life may see this as, why is it so difficult to do that? It just is. So psychoeducation and really getting into the nuts and bolts of SCAD and all the different concepts that we talked about earlier, how comfort precedes communication, building that comfort with peers, finding an activity of interest for them is really important. Again, it's 100% them, right? They're doing their goals, they're needing it, they're wanting it. Really working on action plans. That's a really powerful strategy for adults. And as the kids get older, kind of integrating that into all aspects of their life, different social situations, and how to plan those situations out based on where they are on the bridge. Watch, listen, and learn. Interesting. What does that mean? Well, these adults have gone years really having missed opportunities. So just having them kind of watch conversations go when they're doing their goals, let's say just even going out to the grocery store, just watching other people interact, listening to how they talk, listening how others ask a store clerk something, listening how others give their order in a restaurant, watching people in the workplace, watching people in school if they're in graduate school and so forth. So that watch, listen, and learn, and really talking about that in therapy is really, really powerful and important. Hess is head up, eye contact, smile, and use a big 5-word like hi, bye, yes, no, thanks. And really being very cognitive about it, very aware, planning it, doing it, discussing when you're going to do these different social communication opportunities and these goals and how and where to implement, and struggling through this with them because they'll often when you meet them at their level and you respect that something is hard or difficult, it's amazing how they start to let go and open up to you, because so many individuals in their lives have had such expectation, and mostly because they didn't understand. It was with love, but they often feel very defeated. So when we meet them at their level and really talk to them about these struggles, even the struggles we've had personally, we see that at Communicamp with the teens as well, is how really learning that some of these counselors and the struggles that they go through really do help them. In terms of these adults and as they move along, again, the cognitive restructuring, as we talked about, the identity of self-defeating maladaptive thoughts, I can't do it, to I can do it. And really respecting their comorbidities and working with them on that. The goal of just consistent responding to others, knowing how to initiate their needs and more elaborate speech is a really big area because, as we said, the verbal stage of communication can be just quiet, barely audible, one or two words to more typical normal speech and elaborate and initiative. And that's what we have to work on through the give and take. And again, maybe even doing assignments. We have adults actually asking questions to people purposely, calling relatives, having topic questions, ask me about, and really being proactive in their treatment. We have to be cognizant of the dynamics between parents and adult children. How does this impact progress? Typically, if I'm doing a web conference and I'm working with an adult and an adult's parent or caregiver is with them and I ask a question, inevitably, even as an adult, they turn their head to that other person as if they're waiting for them to respond to them. And that's just from years and years. And so we have to help them through this process and help train the adults in their lives on how to step back and support these individuals with SM that are struggling. When things get complicated, well, the developmental level. So you could have a 16-year-old functioning at a 5-year-old level. You adapt treatment based on their developmental level. And that's really important because we have to understand the different co-occurring diagnoses and comorbidities. As we discussed, we often see these are missed or seen independently. And I ask you, those that are listening to this, do your children, is the adult in your life with SM, do they have learning challenges? The most common being processing. So think about the give and take of communication. Hi, how are you? Good, how are you? What are you doing this weekend? Some individuals, if they're just even socially anxious, without even having any processing challenges or learning issues, they can't put their thoughts together to say it. They didn't even get what was asked of them. So we have to be very understanding, are there some past learning issues? I consulted with an adult recently when all through school, they were being treated and accommodated for a auditory processing disorder. Well, that's going to affect them as they're growing up, and that's going to affect treatment. So we need to accommodate their auditory processing challenges or their speech and language difficulties. Whatever those difficulties are, we have to use that in the treatment or the whole child or whole adult approach here. Parenting styles absolutely affect treatment. We do a workshop on that, very common at Communicamp, where we really talk about how does the parenting style you have affect the treatment of your child or teen. Authoritative, we need to work on that. We have to help them become more authoritative in their parenting style with their child or teen. The school, misunderstandings and conflicts. Can't tell you how many times we'll meet with a family where there's so much discord with the school, and that's really challenging. So that's definitely a complicated situation. And if the child or teen has lack of appropriate accommodations and interventions, and as they age, even in the workplace, does this individual have delays or challenges where they need to be in a position or a job that will accommodate these difficulties?
So overall, it's interesting to know that young children are less verbal in most settings, but they progress quicker. And that stems from that cognitive standpoint, right? Of older individuals are more aware of what's going on. Oppositely, as individuals age, they become more verbal with more people, but speech tends to be more quiet. There's less words, less initiation, less elaborative, right? So that's where we really want to start working a lot more on how can we gain that elaboration? What can we do in this goal work? Also, just lastly, interesting facts here. As children get older, medication may be more necessary and helpful. So that's something you definitely want to kind of tap into and further explore if necessary. Behavior is more conditioned and more likely to have comorbidities like high depression or more worsened anxiety. So overall, if SM is persisting, there needs to be awareness of how these comorbidities are impacting their progress. And that's where we really want to tap into those whys of SM.
We thought of this great reference. It's like a seesaw, and how treatment differs between younger and older individuals, kind of summarizing what we were talking about, knowing this is a continuum. Younger children, it's more behavioral in nature. As the kids get older, it becomes way more cognitive in nature. So CBT is really a humongous part of what this treatment is about, to help these individuals gain the long-term coping skills. When children are younger, we depend on parents, teachers to set up the world for them. Play dates, small groups in the room, taking them out purposely to stores and restaurants, having specific types of games and activities to play at home or in school. As the individual gets older, they're way more active in this process, checking off the goals, working through their challenges. They're not getting stickers, obviously. They're working, the internal motivation is going to come into play more. And so they're working on their goals. It becomes a much more active process. So as the individual ages, although parents and educators are important, of course, but it becomes less and less of the process as the individual ages. And then we talked about adults where really it's all about them with the support of others. Again, games for younger children, and it's adapted to active goals, charts, knowing what they're working on, adapting the goals and charts based on the stage in the bridge. So they may have a goal of giving their order, but it might be based on where they are in terms of nonverbal or using transitional strategies. That same goal of giving order, it can then be branched and bridged into verbal, reading a script or not reading a script, asking choice questions for people asking choice questions, the individual doing more elaborate speech, more initiative speech. The younger they are, again, they relate to things in terms of acknowledging it, being scary, and that acknowledgement and assessment, being able to rate and grade their feelings, starts even as young as 3. We see these kids being able to relate to things being very scary. And as they get older, again, it becomes very hard to do because, again, they're conditioned. So it's not so scary. I give an example of kind of being afraid to swim. You can run around the side of the pool, but it's not until you get your feet wet that you, or think about getting your feet wet, that you start to get that scared feeling. So as individuals age, it's similar to that. And the behaviors become, again, very conditioned. So acknowledgement, rating their feelings, grading their feelings, being able to help and participate in the goal process becomes a much more active process as they get older. High expectation when they're young and how people are talking to them, it really plays a role in their avoidance. And as children get older and older and older, that low expectation where they're shadowing others, because we don't want to ask questions. That's what I hear from teachers and parents. Well, we don't want to ask questions. It's going to make them anxious. So here's a response. If you don't ask, how are they ever going to answer? But we need to respect their stage on the bridge. So we do want store clerks and waiters and waitresses and relatives and teachers to ask questions. They just need to ask questions based on where they are on the bridge, or we can't train every waiter or waitress. So the parent who is with that individual, or as we're working with adults, we have to help them bridge that child into communication when others ask them questions. So it's very important that that shadowing starts to go away, handing over, taking over. Frontline, even adults need to work on that strategy as they're working on strategies to progress into speech. So you're not staying with hand over, take over. We're helping them unlearn their conditioned shadowing ways by using these engaging strategies. And again, we talked about external motivation, the stickers, the dollars, the going on a trip. The external motivation is much more involved with the younger kids, whereas older individuals, it becomes much more their need to do it, their desire to do it. And that's the art of therapy too, is helping some of these older individuals who don't have a lot of internal motivation to be able to do the strategies and do the treatment by helping them get that internal motivation. So we're just about done, and I'm proud of ourselves for making the time. Just wanted to let you know with the Smart Center that we do what we do offer in terms of psychological assessments, testing, for autism spectrum, psychoeducational testing. It's a big part of our center right now, speech and language. We've been doing this and have a whole department. We have individual treatment, weekly therapy, monthly programs. We have our group treatment that most people know about, our Communicamp for 3 to 17-year-olds. We have weekly groups, professional consultations, school-based consultations, student specifics, IEP and 504 development. We are licensed in multiple states to do telehealth, so we are available to you to help you in any capacity. So now I guess we'll get to the questions. You talked about 100 exposures in 10 days. Can you comment on what counts as exposures? For instance, if I train my child to answer questions in the community and someone is asking her 5 different questions that she's answering, do you count that as 5 exposures? I know what you're saying here. Yes, basically going out and practicing. You could go to CVS, and again, respecting where they're at on the bridge. Some of these kids are just handing and taking. Some are just responding through a verbal intermediary and telling their parent or reading a script. So again, I want to make sure that everyone listening to this understands that it's based on where you're at on the bridge and bridging them up based on their comfort and the goals that we set to move them into consistent verbal communication in terms of responding and initiating. But yes, so you could go to CVS and practice 10 times in CVS that one day and get that done with. Obviously, with the way the world is, it's not easy to get all these exposures. We are just trying to emphasize with saying this that it's critical to have exposures. So with COVID, it's been a challenge. I mean, people have been home, they haven't gone out. Some of the families we work with, even the adults we work with, they just haven't gone out. So a lot of kids, unfortunately, if they haven't been in active treatment, have regressed. It's scarier now. So it's definitely a challenge. And with COVID, having those exposures, but we can't emphasize enough. And all the experts this weekend will be telling you how exposures are critical for progress. Jenna.
The second question, so what recommendations do you have for families just starting out to support a newly SM diagnosed teen who also has developmental disabilities? Our son is very verbal at home or in comfortable social situations. So in high school, he has peer mentors to offer support if needed. He has often, went away. Oh, he has always been quiet during class and will sometimes whisper. However, he is getting older. He has been showing that he's feeling more comfortable to talk with others. So, I mean, I think that that's a really great question. I think as we start to get older, having him take charge of some of these goals is really important. So kind of thinking about like the listening, observing, trying to pay attention to what questions are people asking so that he can start to pay attention to how he can engage. The fact that he is motivated and he wants to start engaging in that way, I think is a really great benefit and shows that he's motivated. But I definitely think just offering as many social situations, as many exposures as possible is really important. So maybe finding, a club or an activity in high school that really meets him and really allows him to kind of have that big shot role where he feels the most comfort, I think is definitely recommended. And kind of seeing that level of motivation that he has. Anything that you'd like to add, Dr. E?
No, I think when you're writing this, what I'm also feeling is how involved is he in the treatment? And I think I'm hoping you heard throughout our presentation that their involvement, their understanding this. And as parents, of course, we're going to guide the process, but I would say that really working on helping at the developmental level that he is to be involved in this and his awareness to the bridge and his feelings to doing some of the strategies and goals so that he feels the ownership, which will give him control and honestly confidence. So the next question, is there any work being done to create an IEP eligibility that addresses SM? That would go a long way towards addressing school skepticism regarding SM. As an educator and parent, I am perturbed by schools, for example, separating kids, my daughter from buddies, safe peers, because she needs to make more friends. So I don't think that in terms of being a IEP eligibility, we say what we do is if a child has trouble, it's about functioning socially, emotionally, and academically. So we use that as a guide for their eligibility. Also the ability to get services. So some schools or some states having small groups out of the room that is going to be needs an IEP, where in other schools, it could be a 504 plan. In others, you don't even need that at all. So that's why I think it's hard to make this a clear rule. So it's about their ability to function socially, emotionally, and reaching their academic potential. If they're in the gifted range of they may need a gifted education IEP, but also know that it isn't, if they're not reaching their potential and functioning the way they should, is really the criteria to getting testing done. We usually will see them get testing in the school. We offer, in a lot of centers, independent educational evaluations. If they can't get the testing because they're mute, we do that testing. We will test speech and language and do psychoeducational testing for selectively mute individuals, because schools and a lot of professionals don't know how to assess a mute child. So I think the key here is how much dysfunction are we talking about? Also, the criteria is other health impairment, communication, and emotional disturbance. For me, I hate that last term. It bugs the heck out of me, especially knowing for kids with SM, it's a social communication anxiety, and they may have speech and language issues that's causing their mutism. They may not look anxious at all. They may be anxious, but why label it as anxiety? That's giving it the wrong connotation. So I think that it's really about finding the right clinician and support to work with you, with the school, to help navigate that situation in terms of the IEP and knowing how to plan. For the families we work with, when we do school trainings, we set up how to do the interventions in school, and we train teachers. Like for our patients, we do an initial training for an hour where we talk about SM, but where that child is on the bridge and how they can use the buddy process. And we also will then, work with them ongoing to be able to change that as we move along.
So the next question, how do you motivate a teen adult who is very pessimistic about getting help? So this makes me think of a few things. I think that one thing to consider is what expectations are being placed on this teen or adult. So in this situation, wondering, are there high expectations, whether it's at work or at school, if it's for a teen, at home with parents, what expectation are we placing to speak? So we always try to erase the word talk or speak and try to focus on the comfort of proceeding communication. So how can we implement some of that comfort there? I also think it's important to really meet them where they are. And this is where in the beginning I was talking about motivational interviewing. So really checking in, if they're not ready yet to speak or to communicate, are there things they're willing to do? Are there ways that we can try to meet them where they are and focus on those tasks and focus on those goals, even if it's just joining a club and meeting people, even if it's just going to dinner once a week with, two of your friends and just getting to know them more. It could be any goal, and maybe allowing them to have that control too of what they want to do. So I think giving them the independence, giving them that control, really, really, really crucial to add interest. So like for teens or even adults, even college age kids or students, thinking about like what clubs or activities can I join to really meet my people. So at least we're trying to just socially engage and trying to meet them where they are, I think is the biggest piece.
Yeah, and really respecting that. I mean, the beauty of the bridge is that a lot of these kids have expectations for speech over time. It's all about speaking, right? If they understand where they are on the bridge, then it makes them feel safe that just handing and taking, just you taking them out, even without awareness in the beginning, where you are putting them on the front line. And then when you're working with your clinician, you actually start with the areas that they can do so that they see, I can do this. It's also the consistency of doing the goals, going to treatment and so forth. We see this a lot with teens and adults where the motivation is an issue. When they're in school, we do want to work with teachers. One thing we have to be careful with is if they're very avoidant of this and they don't want anybody to know, we don't involve them in that process as much. Unfortunately, we can't because they'll shut down even more, but still having to educate teachers on how to set up the small groups, how to set up the strategies so that without even realizing it, we're meeting them at their level by teachers implementing and you implementing. So it isn't even about treatment, it's training you as parents and teachers on how to bring that individual into communication without even their awareness. It's just how do you change conversation? How do parents, and also areas of interest. We often have to rely on teachers to set them up with kids. With adults, it might be a hobby that they're interested in. Sometimes it's just doing something with a cousin or a sibling at first, just to be able to get them out to start to do things. That's one way to go. That's another way to go. How do parents educate providers? There's lots and lots of ways. The Selective Mutism Association has a lot of resources at the selectivemutismcenter.org. In our resource page, we have a webinar, What is SM? We also have a pamphlet about helping, just what you're saying, understand selective mutism, helping parents educate others on selective mutism. It's an actual pamphlet. We also have something called About My Child, when I'm working with the teen, we'll often have the teen write about what they're about and how they can educate others themselves as they're involved in treatment, if that is something that we can do with the teen or they want to, even younger folks. So the About My Child is a wonderful worksheet that you can give. And again, it's on that resource page. We do take international clients. It's difficult with telehealth license. It's really difficult. We will do interviews and do coaching and education for our international clients. It's difficult to do telehealth unless we're licensed in that country. Can you provide virtual school trainings? We do that every single day. Jennifer Brittingham is our school training expert. She's been doing this since, gosh, early 2000s. It's a huge part of our work is working with schools directly, whether they're patients of ours or they're hiring us, either the school's hiring us or the parents hiring us. We do trainings all day long. Go ahead, Jen.
Oh,
It actually looks like we're out of time. So thank you both so much for this great presentation and for answering so many questions. I think we're going to take a brief break in our conference and we'll see everyone at 3 o'clock.
Can we write our answers in and then the people that wanted their questions answered, we can still do that?
Absolutely. Go ahead.
So can this be live and then can we say it out of the tape or can we, like, what would you like us to do?
You can type the answer in the chat to responding to the Q&A.
Okay. All right. Thank you so much.
thank you so much, everyone.
Thank you, everyone.
Thank you. Okay. It looks like it's hard to know if everybody's here still. Okay. Thank you so much, everyone, for joining us. I would be great, Jen, if we can write our answers to some of these things, you know what I mean, for them. Yeah, so I guess as people leave, let's see here. What you just mentioned is exactly where we have been. Whoops, wait, it's moving. What you just mentioned is exactly where we have been. We ended up with SM diagnosis while in the neuropsych eval, but they couldn't complete the eval. How do I push forward on that, and should I? I think I'm just going to type just in case that individual is not there. I think it's about if it's, I'm going to be able to have difficulty typing with the way my computer is. If it's suspected, there are additional challenges. For example, learning, development, etc., etc. Then finding a center or a professional who has strong, experience working with this population.
I just actually got a message saying that I need to close out the session now. I'm so sorry. But if they didn't get a chance to answer your questions, then could they email you?
Oh, yes, please. That would be awesome. I just don't want anybody to feel they didn't get their questions answered.
Amazing. Okay, well, thank you both so much for this presentation.
And then would you be able to tell me how to upload the handouts and stuff and send me an email on that? Thank you. Bye, everybody. This was
Bye, everyone.
Bye. Thank you, Shira.
Thank you.